Good afternoon, everyone. Some of us in the work group feel that the publication of these new guidelines for asthma in Singapore provides an opportunity to create a revolution in asthma care in Singapore. Yes, a revolution. Because we feel that we have successfully translated major new advances in the understanding of asthma management into practical, simple, and totally inexpensive toolkits which can be used, applied directly by general practitioners in their clinics today with little investment and little training. For my presentation, I will describe one such toolkit which links drug treatment or pharmacological treatment of asthma to control. Now, control, as DMS suggests, is now the key operating word in asthma management. Both the consensus is global, so it is reflected in the recent update of GINA, WHO asthma initiative, and also in the American guidelines, their latest edition, which were published in late 2007. And it is also part of the Singapore CPG, which is a little bit more current than the two major guidelines, and it is a further distillation, and most important for all of us, a further simplification of these guidelines to achieve control with the simplest possible methodology, the simplest possible treatment plan. So for this section of my talk, I suggest that for the drug treatment to achieve control in asthma, for all of us, whether it's a specialist or a GP or a pediatrician in a clinic, it requires only 3 steps: 2 questions and 1 action step. The first question is, what is the treatment the patient is on? And I'm referring not when you see the patient with asthma, especially a new patient, not the treatment the patient is currently receiving for the current attack. It is what the treatment the patient has been receiving as maintenance treatment in between attacks. So what is the treatment the patient is receiving regularly to prevent an asthma attack? That's what we mean by current treatment. Long-term treatment we mean, yeah? So when we say asthma treatment steps, these treatment steps refer to long-term, regular, daily maintenance treatment. And that's categorized into 1 to 5. 5 refer to a specialist. And most of us who treat asthma patients will be familiar with these 4 or 5 steps. It's fairly straightforward. It's in all the guidelines. First step is PRN use, reliever. Step 2 is low-dose inhaled steroids. Step 3 is low-dose plus add-on. Step 4 is medium dose, but it's very straightforward, yeah? We added in step 1, you notice there is a caveat that in some cases, you may actually use inhaled steroid PRN in very mild, perfectly well-controlled asthmatics. So that's a slight refinement of step 1, yeah? So it could be PRN, inhaled steroids, or PRN quick relievers, yeah? I'll just elaborate a little bit on what the dose ranges we are talking about in terms of medium to high dose and the add-on agents. Most of us are familiar with these dose ranges and the drugs, and they have also been alluded to by DMS. So I will not elaborate in great detail. These are the commonly used inhaled steroids, the dosages, and the add-on agents, yeah? The most popular, the most widely used, and the most cost-effective combination is basically of an inhaled steroid and an add-on agent will be inhaled steroid and one of the long-acting beta agonists in a single device. So it's inhaled steroid plus LABA, single device, yeah? Either Seretide or Symbicort. I only need to spend 2 more slides to discuss when you consider what step the treatment the patient is receiving, there's a possibility you may want to identify a high-risk individual who may require further evaluation and further referral. So these criteria, if you see, please be careful. If you are not sure what the diagnosis is, if there are major comorbidities which require assessment and treatment by their own right, if a patient is experiencing very poor asthma control despite on step 3 treatment already, yeah. The 4th item, very important. In primary care, we believe no patient, 0 patients should be receiving regular oral steroids to prevent asthma attacks. Even low doses should be 0. In fact, most of it, even our practice in hospital nowadays with new treatment plans, I think I cannot remember a single patient on everyday oral steroids under my own personal care. So certainly in the primary care, in the clinics, they should not be, so if a patient comes back to you regularly and asks for that breathlessness pill, even a small dose PRN should be considered very carefully about high-risk patient and risk of fatal asthma. The high risk for fatal asthma has these following characteristics: loss of severe exacerbations, loss of hospital attendance, especially ED attendance, requiring lots of rescue medications, having experienced severe exacerbations before, resulting in loss of consciousness, seizures, ICU admissions, and other risk factors regarding in terms of poor socioeconomic background or recalcitrant or frank denial. So be aware that as you evaluate asthma treatment steps, intensity, some patients may require further evaluation, even if they responded to your immediate treatment for the acute attack. We see very often patients who respond transiently to GP's treatment in the clinics and they go home and come in and die 6 weeks later, 6 months later, because they run out of medicine, they default follow-up, and then they come in crash, severe, fatal. Very, very often it happens. So be careful. When a patient leaves your clinic, be careful. Run over your head, your mind. Is the patient having a risk profile? One major risk indicator is ethnic minority. Ethnic minorities, current smoking. These are two other risk factors. Be very careful. Once you identify the level of maintenance treatment the patient is on, the next question is, question number 2 is, what is the level of this patient's asthma control? And again, we're asking about level of control in between exacerbations. What's the regular level of asthma control? And for that, GINA WHO has a table. It's too complicated for me, so I don't remember this. But just have to remember that there are 3 categories, control, partial, and uncontrolled. And some of these things like daytime, nighttime, cannot go to school, lung function, and exacerbation frequency. But frankly, this table, even though simplified and pared down, is too complicated for me. So I don't advise you go and memorize it. And the Americans come with the same thing. Again, several items: well, not well, poor. The Americans have, in addition, this thing called validated questionnaires in numbers. So they summarize the control criteria in a few numbers, and they have these things. And these are the ones that we have looked at. And these are the major new toolkits that's going to make a real difference, we think, in asthma control in the world, and in Singapore, of course. These are validated questionnaires which patients will fill themselves and which are just as good as any other method to assess control. And my colleagues will in subsequent presentations discuss the background, the methodologies, and the science behind these so-called validated measures of asthma control in numbers. One number, we choose ACT score for various reasons, which we will elaborate as we go along. And we use ACT score and say this is the control indicator. In other words, this is your HbA1c. This is your blood pressure. This is your lipid level. This is your LDL level, to control asthma, the analogy, And it's even better than HbA1c, better than BP, better than LDL levels. Why? Costs no money. And patient can do self-evaluation, just as valid, meaning patient come into your clinic, show you the number, it's just as valid as you doing it in the clinic per se, And at the bottom line, we just took a cutoff at 20. Anything around 20 points and above is considered satisfactory, good control. Anything below that, lousy. Good control meaning carry on treatment or step down. Below that, step up, So the next action step is, it follows step of asthma treatment intensity and quality of control. And summarized in this particular flowchart. That's it. In other words, if it's more than or equal to, so you say around 20 points, then you either maintain the treatment or step down, depending on what level of intensity the patient is on. We allow personal judgment between between your patient and yourself. You decide. If it's close to 25, can step down. If it's around 19, 20, better maintain. All right. So there's a range within that. So you can either maintain or you can step down. If it's below 20, below 19, close to 15, better step up. So it's very straightforward and very so-called simplified. Just one number, one test, costs no money, and for the patient to do it in front of you, less than 5 minutes. So doctors cannot complain anymore. Oh, no time, too busy, too complicated. Just one number, 20, around 20. The other steps will elaborate action plan and other educational factors which need to be reviewed for each patient visit. The next 2 or 3 slides, I will show you what X-score, how X-score performs in the Singapore setting. Yeah? Firstly, X-scores in the Singapore National Asthma Program, or SNAP itself, different hospitals. Yeah? The grey doesn't come up. Yeah? So between 15 to 20 is considered lousy. Yeah? So when it came into the program, first visit, yeah, the average X-score is around 13 or 12. That's considered terrible, very poor control. Yeah? Within one visit, you're hovering around 20, which is considered just satisfactory, right? The average values or the mean values don't reflect the actual profile. The profile is better seen as a frequency histogram. So this will be the X-scores in the first 100 visits after the first visit. So after they've entered a program, the X-scores, although the average is around 20, actually the scatter is well within the 20-25 range. Yeah? But this mean value is actually skewed by low numbers. So there are several patients which have very low numbers which skew the mean values. Yeah? So the histogram gives you a better idea of the achievement. Of course, we cheat a little bit. We say around 19 can do. Because our nurses tell us that our kind of patients are very hard to hit 20, man. So we say, okay. So if we hit 19 and above, we say satisfactory, then more than 80% of patients in hospital setting are achieving reasonable control, safe control, after the first visit. Even more interesting for GPs is we have data in Singapore on the use of X-score and its performance under GP hands, because we have a small group of patients, about 250 patients, middle-aged patients, 70% Chinese, 50% Malay, who have been undergoing a so-called treatment program undertaken by GPs, where they had their X-scores measured before and after they entered a treatment program. And look at the GPs, although before they entered a program involving combination treatment, around just below 20, well above 20, within the first 2 visits after enrollment. And the histograms are even more interesting, So about 260 patients, 260 measurements of asthma control tests before, white scatter, After that, most of them, again, just like in the hospitals, clustered around above the 20 score. In fact, under GPs, the X-score is even better than specialists. The average value is 20 plus, and the scatter is well above 20 for the majority. So these little experience and little experiment tells us that actually X-scores can be valuable tools both under specialty and GP hands. And we are suggesting that actually this X-score gives us level playing field. Both specialists, pediatricians, GPs, we're using the same methodology, measuring with the same instruments, asthma control. And we expect that actually from this preliminary experience that under simple action plan and simple treatment programs, the X-scores will reflect excellent control if monitored regularly under current conditions. Therefore, my last slide, the asthma management steps I suggest to you in a simple clinic visit. The first question is, what treatment step is patient on? What is the X-score? What is the quality of asthma control? Then adjust according to the level of ACT. If it's 20 or above, maintain. If it's below 20, add up. If it's close to 25, reduce. Reduce one step. And then further patient education regarding inhaler techniques and so forth. And if an action plan and a follow-up plan. So friends, we hope that as we all try and implement this sort of a closed-loop system linking X-score with drug treatment intensity in our asthma patients more consistently, both specialists and GPs, we may help to achieve better quality of control among our patients and lower level of burden of disease among our asthma populations more effectively, and therefore achieve a real revolution in asthma care in Singapore. Thank you very much.